You lost so
I'm
much
sure.
weight, madam.
Hello, everybody.
Parna, you are talking to me?
Yes.
This is virtual effect. Virtual effect.
Don't say that.
Good evening,
Good evening.
everyone.
Good evening, Dr. Indrani.
Good evening, Anita madam, Indrani madam.
Good evening, sir.
Good evening.
Shilpa
Looking
madam
forward-
join झालं. Saurabh. Nitin Nandanwankar join झालं.
I have just reached home, so I'm not putting my camera on. Good evening, everybody.
Good evening, Rajesh sir, Anita madam, Avinash sir.
Manisha madam, good evening.
Good evening.
Good evening, sir.
Good
Vivek sir,
evening.
good evening.
काय
लगेच
म्हणताय?
भेटलो 10 दिवसात.
कुठला
10
look आहे?
दिवसात we are meeting.
Ready?
15 ऑगस्टचे फुगे अजूनही होते.
15 ऑगस्ट से काय?
15 ऑगस्टचे
फुगे
बलून
दिसतायत.
अजूनही जिवंत आहेत.
Yes, yes.
कुठे?
Hi, Anjali.
Good
Anjali,
evening,
Basket
hi.
कोणाची
ma'am. Hello,
basket आहे?
ma'am.
Hi.
बास्केट कोणाची
sir?
आहे?
Manisha
Basket
madam
कोणाची
चीच
आहे?
आहे.
नाही प्रेसिडेंट इलेक्टची हो अविनाशची.
श्रीलेख स्क्रीन शेअर करून घे ना. हॅलो
गणेश तोपर्यंत स्लाइड्स वगैरे काय असतील तर चेक करून घ्या सर.
रिलेक करतोय. रिलेक कडे आहे सगळं स्लाइडचं.
हो 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 श्रीलेखला सांगितलंय. श्रीलेख आलाय का तू कोहोस?
आज
आता आला.
आणि आजचा वेबिनार हा डॉक्टर विवेक चकुले सर आणि डॉक्टर श्रीलेख हे दोघच कंडक्ट करणार आहेत. हॅलो.
येस सर.
हा ऐकतायत सगळेजण.
ऐकतायत ना? ओके.
हो हो येते. यू कंटिन्यू.
सुरू करूयात.
हा एकदा स्लाइड झाले का बघा. एकदा झाले का?
बालाजी सर.
हो चालू करू
बालाजी.
शकतो. येस.
ओके. Welcome to all SAMS members. Basically, today's webinar is on simulation, the revolution in the medical education. This is a recent advance in the medical education, that simulation and simulators have come for our study in all the institutes, and we are not behind to adopt all these things for the different scenarios in the medical practices in the teaching institute. I would like to request Dr. Balaji Asivakar sir to introduce or to brief on this webinar series. Dr. Balaji Asivakar.
Good evening to all of you, and this is probably it is the last meeting of my tenure of recent advances. And recently we visited Wardha, and where we happened to see simulation lab, and it is shown by Dr. Vivek, and we were so much impressed with that lab that we immediately decided that the last activity of my tenure should be on simulation. So we requested him to organize one activity at Maharashtra state level on simulation, and he immediately agreed for that, and I am really thankful for him for arranging today's webinar. And as all of you are excited to hear about simulation, this is a new way to learn the things learned in anesthesia, and it's we are going to learn it. We all will get benefit from it. So without wasting much time, I request organizers to continue the program. Thank you very much.
Sir, good evening.
Unmute.
It's really my pleasure to host this webinar. As Balaji sir already said, his order is always accepted, will be always accepted. He is my teacher during my post graduation also. So let's start next. So this is the webinar organized by Society of Anesthesiologists, Maharashtra State Branch. Next, I am thankful to the office bearers of the Maharashtra State anesthesiologist, Asegavkar sir, Rajesh sir, Avinash sir, Nehete madam, Vikas sir, and Parna madam for giving me the opportunity for this webinar. Next, please. So we have decided some learning objective for this webinar. So we are starting from basic of the simulation. What is simulation? The role of simulation in anesthesia, how SimLab can be developed, and cognitive to non-technical skill to heal in simulation. Next, please. So I would like to introduce Dr. Srilekh Mankher. He is the assistant professor in Department of Anesthesiology in JNMC Saungi Meghe, Wardha. He is a Mayo trained USA certified simulator instructor, and he is doing very good job in our simulation lab. He knows from technical part also for the simulation and the cognitive part of the simulation. He runs all the scenarios in our lab, and he is the key person in our lab. I request Dr. Srilekh Mankher to speak on the basics of simulation. The simulation, which is a revolution in the medical education. The revolution in medical education. Dr. Srilekh, please let us know what is the simulation and how it has been revolutionized the medical education. Thank you very much.
Good evening, everyone. Thank you, Dr. Vivek sir, for saying so many good words for me. I would also like to thank the ISA Maharashtra State for giving this opportunity to share our experience about simulation via this webinar. Now, I would like to share just a minute. Coming to the topic for today, simulation, a revolution in healthcare education. What is simulation? Basically, simulation is a technique and not a technology to replace or amplify real experiences with guided experience that evoke or replicate substantial aspect of real world in a fully interactive manner. It can also be defined as a simulation is an innovative teaching strategy that facilitates experiential learning in a safe learning environment. If you go by the definition, you will come to know that here we try to replicate the real world experiences as near to the reality, so that the students who may not be ever exposed to that situation, or a person who has exposed to that situation many times but not in a guided way. So simulation brings to the platform where we can bring this innovative teaching strategy for the experiential learning in a very safe learning environment. Coming to the intro, like how simulation was introduced. If we go by the timeline, the modern simulation education was introduced around 1929 via Link Trainer. Then it progressed via Rescue Annie, Sim1, and Harvey Cardiology. This is the timeline which I will like to explain one by one. We owe the initial development of medical simulation, modern medical simulation, and patient safety to aviation simulation. Why I am saying so? Because if you go down the history, the first effective simulator was developed by Edwin Albert Link in 1929. This was a flight simulator, also called as a blue box or a link trainer, link named by the inventor, which you can see in the photograph also. Here in this simulator, Link assessed the current scenario. According to him, many of the like accidents and mishaps happening in the aviation industry were due to lack of preparedness for the critical scenarios. So what he tried to do with the help of this flight simulator, that he created so many like simulated situations where the flight like air pilots and all, they can train themselves how to deal with the crash landing, how to deal with the bad weather, how to take important decisions in a critical scenario, how to be a team leader among the all the professionals. So this link trainer became an important link for even a medical simulation. So this point of view, I said that link trainer, for link trainer, we owe a very important like owe a lot of respect for the aviation simulation. Second thing, in we also took an inspiration from aviation simulation by from CRM. CRM is like a crew resource management. So this crew resource management was also developed in 1970s, that deals with how to go ahead in a critical scenario situation and how to take important decisions. So from medical simulation point of view, we developed ACRM, that is anesthesia critical resource management. This was developed by David Gaba, and David Gaba was highly impressed with the CRM from aviation simulation. Then coming to the first important modern medical simulator, that is Resuscitni Annie. In 1960s, Dr. Peter Safar, he was working in a Baltimore hospital. He was known for his rediscovery for mouth-to-mouth resuscitation. Then along with the help of Norwegian anesthesiologist, that is Bjørn Lind, they convinced a toy maker, that is Asmund Larder, to develop and produce the realistic model of a human torso, allowing the application of Safar's the basic maneuver what we know to relieve the airway obstruction, that is head tilt and chin lift, so that we can deliver the mouth-to-mouth rescue breaths. Later, they also added the spring into the mannequin so that we can allow for chest compressions also. So this Resuscitni Annie has made an important landmark in current task trainer development. What we do usually for CPR mannequins, this was the initial mannequin from where most of the today's task trainers have been developed. Then coming to the Sim1, this was regarded as a death-proof patient for student doctors. Why it is so? Because this was the first ever computer-controlled patient simulator. It was developed by an engineer and a physician, Dr. Abrahamson and Dr. Denson. So the important why it was labeled as a computer controlled, because it had the 5 important components like computer, interface unit, instructor's console, anesthesia machine, and mannequin. It replicated a lot of physiological responses like breathing, blinking eyes, pupils that can dilate and constrict, a movable jaw which you can intubate, you can use to intubate. Then it can simulate heartbeats, temporal and carotid pulsations can be felt, and even blood pressure can be measured. Basically, the Abrahamson and Denson developed this simulator so that they can teach their residents how to intubate, and simultaneously also they can have a little bit of higher fidelity kind of simulator also. The biggest demotivator for not getting this simulator famous was the cost. During even the 1960s, the cost was around $1. $1 lakh, and because of this huge cost of development, the SIM1 was unluckily made as a only simulator. It was not produced at a larger scale. Only one SIM1 was produced, and it was limited only to the institute. Then coming to the more important cardiology patient simulator known as Harvey, it was presented by Michael Gordon. He was a MD and PhD faculty at University of Miami. This was a kind of diagnostic trainer because it can simulate many cardiac diseases by presenting varying auscultatory findings, blood pressure, pulse findings, and it also remains today also in service in many medical schools. Then one more innovation which came to the faculty of simulation was a simulated and standardized patient. How different and how educational innovation it brought to the field of simulation was that first it was introduced by Howard Barrow, who was a neurologist who developed a simulated patient and programmed patient to assess his medical student for neurological examination. Here we also see many a times that by repeated examination, the actual patient really gets irritated, and he might not give the response what we expect. And also it will be difficult for even assessing a student on the basis of the patient who is not in the mood to share his history properly. So what they did, they standardized the patient, they trained the patient, and in that scenario, even the patient will give the exact history what we are going to assess, and the student will be assessed not just by the examiner, but even that standardized patient will also rate the student. He will also can like how the like student is talking to the standardized patient, that will be rated by a standardized patient. Coming to the one more additional development, that was CASE. CASE is a comprehensive anesthesia simulation environment. It was developed by David Gaba, an anesthesiologist who had a very high amount of contribution towards the simulation in anesthesia. They developed this prototype of a mannequin simulator where like human performances in anesthesia were investigated. It underwent various upgrades like 1.2, then 2.0, and later it got commercial success via CE links. Then coming to the modern age simulators, which we are routinely using in our setup also, and which we have seen in outer side setups also, like HPS and SIMMINE 3G. These are produced by one of the simulation giants like CAE, which is known as Elevate Healthcare, and also by Larder. Coming to the today's time, like going down the history, we can see that like these are the news which I'm sharing on screen are almost from May 2024 and July 2024. From here, we can understand that simulation has come to the point where we are using virtual reality, mixed virtual reality technology via devices like Apple Vision Pro, and surgeons can do wonder with the help of these devices. They can simulate the things, and they can even perform surgeries way better compared to the existing things. Now, is simulation really a recent development? If we go down the history, we can see that the simulation has been practiced since the evolution of our civilization. Like if we go to the Babylonia civilization, we can see that the clay liver, the first image, you can see that the clay liver was used by them to understand the human ailments. If we like our own Sushruta, the Sushruta was also known for his discipline regarding his disciples. He used to ask his students to first practice the surgical skills either on bottle guard or pushpa phala, what we usually called as kaddu, or like lauki. There they will used to practice all the incision, like how to put an incision. Then they used to about other skills like venesection. They used to teach on dead animals. They used to even teach on tubules of water lily. So if we go by other civilization, like a Chinese civilization, many dynasties have used ivory made female mannequins where because during that time males were not allowed to examine females. So whatever medical education regarding female surface anatomy or anything has to be given, they used to be imparted via this ivory mannequins. Then coming to the most important part, like why simulation is important. The first and foremost important thing for bringing simulation into the medical field was patient safety. Patient safety was, is, and will always be the major force for propagation of medical simulation. Like even the prominent organizations related to anesthesia, like Anesthesia Patient Safety Foundation, it also says like no patient should be ever be harmed by anesthesia. If you go to the first simulation lab which was introduced, like ever established in the world, that is Boston Sim Lab, it says that never ever first time on a patient. Like we should never ever learn any skill on patient directly. Though since time being we have seen that this is how people have learned their skills, either directly working on the patient or maybe on the kind of dead bodies, they have learned their skills. But when we come to the today's era, where the patients are really conscious about their rights, where the privacy of the patient is paramount, where the autonomy of the patient is paramount, legally also and ethically also, during this time, so simulation comes into the picture, because simulations gives enough flexibility, and also it respects the privacy of the patient, so that we are not, whatever we are practicing, we won't be patient won't be the first patient won't be the first interface. We must practice all the skills on sim lab, on the simulator, and then only we should go ahead with the actual patient dealing. Then simulation is also important for interprofessional education. Why interprofessional education I am saying? Because when in a medical field we are working together, we should learn also together. Working together is as important as learning together, because when we are dealing in any crisis situation, it all comes down how we are managing the resources, how we are distributing the work, how we are working as a team. So to succeed as a team, we should learn all the skills as a team. Like suppose a scenario is there where a crisis situation is there, where a surgeon is there, a nurse is there, a technician is there, then being an anesthetist, you are also there. So being an anesthetist, you can always take a leader role in a situation of crisis, but you need to work as a team, you need to allocate work. So if you have worked together during simulation, then you can work better during actual crisis situation also. So for interpersonal education also, simulation is very important. Then one more thing simulation provides is it's a very good approach to learning. Now almost all over the world, the education has come towards competency based learning. Even the NMC and all other multiple like para boards like Dental Council of India, Ayurvedic Council of India, like all Indian medicines, even Nursing Council of India, they all have made simulation mandatory, so that they can go ahead with the competency based learning. Coming to the one more thing which simulations brings is the skill evaluation. Like rather than evaluating the students in a real life situation, it is very easy and good to assess the students in a simulated environment, because it makes them like it is very psychologically safe environment, so they can do without fear. There are no punishment for like mistakes. You can repeat the mistakes, you can afford to repeat mistakes. So simulation also brings a good way to evaluate also. Then coming to the anesthesia point of view, like what is the role of simulation in anesthesia? What I already like said, key to ensure that no patient is harmed by anesthesia, as a motto of Anesthesia Patient Simulation Safety Foundation, we can see that there is a major role by an anesthesiologist in development and procurement of simulation. We have few famous anesthesiologists who have worked in the field of simulation like James Phillips, David Gaba, then Michelle Good. How we can use simulation in anesthesia? We can train residents, we can train faculties, we can train anesthesia nurse, we can train anesthesia technicians via simulation. We can introduce new clinical techniques. Like there are studies that how the remifentanil was first utilized via simulation, and then it was practiced outside, and it brought a very good results. Then we can assess our resident performance. We can also use as a faculty development and assessment program. We can we can use it as a continuous medical education. We can also make it a kind of certification thing, like maintenance of certification in anesthesia, where a routinely certification is required after 10 years of duration. Even we can use simulation in the practice of anesthesia when a person is coming back to anesthesia practice after a long duration. So to make the re-entry of an anesthetist into practice, we can use simulation for that role also. Then how to go ahead with simulation? To go ahead simulation, it is very important that we should know our purpose and aim. Purpose means, is it for educational purpose? Is it for training purpose? It is for performance assessment? Is it for rehearsal purpose, or it is for research purpose? We can use simulation according to our purpose and aim. Coming to the unit of participation, we should always know like what kind of participants we are going to teach or we are going to deal with. So being a facilitator, it's your important duty to know your learners, and also whether your learner is an individual person or it's a group or it's like a crew or an organization. Then coming, like you should also know before going ahead with the simulation, what kind of knowledge or skill or attitude or behavior or all these things, all these 4 things you need to like impart on the learners. Then also education of patient being simulated also should be known, like whether your simulation is related to pediatric simulators, geriatric simulators, or any like adults or other scenarios. Coming to the site of simulation, there are multiple ways where we can conduct a simulation. Either it can be an office or school, either it can be in situ, either it can be a physical task trainer, or it can be a replica of an environment. Replica of an environment, I mean to say that you can replicate whole scenario. Like you can replicate a scenario of an ICU in the sim lab. You can replicate a scenario of an operation theater into a sim lab. You can even like replicate like scenario of an emergency room into a sim lab. Only thing, you should try to make it as realistic as possible through all kind of fidelities. Then coming to the extent of participation, how much extent you expect from participant, like how much level of extent of participation you are expecting from the learner. Are your learner only observer? Are your learner going to perform any skill? Are your learner going to do any hands-on skills? Or are your learner going to play a part in a high fidelity simulation where they will have a very immersive kind of experience? Then coming to the feedback is always via assessment, where you can go ahead with the debriefing portion of the scenario, which I will come to later part of the presentation. Then coming to the second portion of our presentation, like how to go ahead with the simulation, a sim lab. Like there are multiple agencies which deals with the regulation in India, like NMC, Dental Council of India, then Indian Nursing Council, then Alternative Indian Medicine, like Ayurvedic Council of India. These also deals with the rules and regulations regarding sim lab. Coming to the NMC, the National Medical Council has specifically mentioned that like there are 2 boards, undergraduate medical education board and post-graduation medical education board. The undergraduate medical education board has clearly explained like for how much intake capacity of MBBS student, how your facility should be. Suppose if you are having a 150 student capacity, then your the area of your sim lab should be minimum 600 square meters. If the range is of 200 to 250 MBBS student, then it should be around 800 square meters of area. Then they have specified almost everything. Even by postgraduate medical education board, they have specifically told that all the institutions who are going to impart postgraduate medical education, they should have a fully functional simulation laboratory for the training purpose. Now, here we have a very good opportunity to share how our lab is. Like our lab is almost like 12,000 square feet area wise. It is one of the largest and most state-of-art skill lab in central India. We have all kind of fidelities like low fidelity, mid fidelity, and high fidelity. This progression is based on the technology. The low fidelity is kind of task trainer where we can teach the cognitive skills and technical skills. In mid fidelity, the little bit of advancement will be there, where some more computer based features which will be included in the fidelity. And in the highest fidelity, where there is the computer advancement and monitors and all the physiological responses will be included in the simulation. Coming to the low fidelity zone, in our low fidelity zone, we have IV arm, IV injections, subcutaneous injections, then central venous catheterization fidelity, then AHA certified BLS and ALCLS mannequins, then skin, leg, arm suturing mannequins, then gynecological examination models, catheterization training lab, and wound care bandaging. In mid fidelity, we have nursing Annie, where the nursing skills are trained. Then we have Juno, where including undergraduates and nursing students both are trained, where we can give a unique combination of basic plus advanced scenarios. It also allows of changing all the vitals according to the scenario, and you can attach IV fluid and do a mid fidelity kind of scenarios on the Juno. Coming to the high fidelity zone, in high fidelity zone, we have HPS, SimMan 3G, SimMom, that is a obstetric and gynecological fidelity. Then we have US Mentor, that is USG guided. All the USG guided high fidelity things we can conduct. Then we have a Lab Mentor, and we have an Anatomage, where it's a digital table which you can see in the 6 number corner image. It's a 3D interactive image table where you can go on dissecting layer by layer on a human surface. Then coming to the high fidelity thing, we have HPS, where you can the HPS is a by CAE, which is CAE Healthcare. Now it has changed into Elevate Healthcare. The HPS is very good quality of high fidelity mannequin, which can mimic all the human responses like blinking of eyes. Then you can intubate it. You can make a scenario where you can artificially create a difficult intubation scenario by swelling the tongue. Then you can do literally needling or even ICD insertion for pneumothorax. Then you can auscultate the patient and you will be hearing all the breath sounds, abnormal breath sounds, normal breath sounds. Then you can auscultate all the abnormal cardiac sounds. Then you can catheterize the patient. You can monitor the urine output. Then both arms will be giving radial pulsations, all kind of pulsation, carotid pulsation will be there, radial pulsation will be there. You can cannulate, you can take an IV access on both limbs. Then you can even go for SPC insertion. This mannequin is provided with multiple skins. You can routinely change the skin if it is tampered because of multiple uses. Coming to the SimMan 3G, SimMan 3G is produced by Larder. It is also a very good high fidelity mannequin. It also having the all similar kind of features which we can use in HPS. In HPS, you can, like, when you connect the monitor, when you connect NIBP, it will reflect the blood pressure. It can reflect all the vitals on monitor. You can defibrillate the patient, cardiovert the patient. You can use it for pacing. Then it can detect all the anesthetic gases. You can use your modern anesthesia machine along with the HPS. So it is a very good simulator from anesthesia point of view. It is as good as that it is made for anesthesia. So HPS is a very good high fidelity simulator which we are using routinely. Then coming to the actual running of a scenario, what makes a scenario? Now I have shared a template for a scenario. A scenario should have a course title. Like here, for example, I have shared a course title as ventricular tachycardia followed by cardiac arrest. Then it should have a complete clinical diagnosis. It should have adequate patient information, like what is the age, what is the like associated disease, any significant history. Then there should be a brief information for facilitator. You need to be very clear about learning objectives. What is learning objective? Learning objective means, like, if you are running any scenario, you should know what you are expecting from students, what are the aim for your scenario, and you should be very clear, and it should be set according to the learners. Like if your learners are undergraduates and you are running a scenario for ventricular tachycardia followed by cardiac arrest, you are not supposed to expect that they will cardiovert or defibrillate the patient. What you can expect at max is, in that scenario, your learning objective will be, they should identify that this is abnormal rhythm. At max, they should go and assess the rhythm, and they should label it as an ventricular tachycardia, well and good. And the most important thing, what we expect from undergraduates is, they should call for help. So when you're, so the point is, when you're deciding about the learning objective, it all depends what kind of learner you are facing. If you're learning undergraduate, set the objectives according to that. If your learner is a anesthesia resident, then you need to upgrade the learning objectives little more. Here you can expect that not just the call for help, they should secure airway also. They should start CPR. They should give a good quality CPR. It should be effective enough. Then they should make a team, including team. Someone should lead as a team leader, and he should allocate the roles to the rest of the team. And they should also like order some investigations. Suppose you are in third scenario, if your learner is a faculty, then you will expect more. You will expect that they should tell the exact, like not just a leader, one person from their team should also take a role of CPR coach. They should use all the essential utensils like CPR board while performing CPR. They should use step to deliver effective CPR. Then they should go on assessing. There should not be any breakage of chain while resuscitation. And also there should be a more kind of communicative efforts from the learner, like they should communicate everything to their the patient's relatives also, like in a scenario. Then coming to the setup and preparation, this is the most important part of a scenario. When you are like you are creating a scenario. Suppose you are creating a scenario where you are assessing your students in an OT setup. Suppose you are assessing your residents for a cardiac arrest inside an operation theater. Then your setup should look like an operation theater. There should be an anesthesia machine. There should be a suction machine. There should be a adequate monitor. It should be, patient should be draped. There should be defibrillator. It should mimic like a OT scenario. There should be if OT table, if not a kind of bed will also do. There should be surgical drapes. A surgeon should be there. Surgical nurse should be there. Anesthesia technician can be there. In a way, I mean to say that your setup should always bring the maximum realism in your scenario. Then coming to the console. Console is something, it's a computer device from where we control all the all the physiological responses in a patient. Like one person will be sitting on that computer, and when any resident whom you are assessing, if he is giving like a beta blocker for a tachycardia, then you should change the heart rate from the console towards a normal sinus rhythm. So the person behind the console is also very important. You have to assign a role either to a technical person or a person among the team who is having adequate knowledge. Then mannequin also you need to specify in the template of the scenario, like what kind of fidelity you are using, low fidelity, high fidelity, mid fidelity. Then also you need to mention the software. You need to mention the event trigger. Suppose in this patient, in this template which I have shared, if I am sharing a scenario of a cardiac arrest, then I have to mention the event trigger, like what triggered for the cardiac arrest. Then candidate handing over is very important. When you are running a scenario, one of the person among the facilitator will give the handing over of the scenario to the learners. That handing over should be in a SBAR format. It is very important that each and everything should be given during the handing over. Then coming to the role allocation is very important. Usually role allocation is done by the learner itself. If there is a team of 4 learners, they will allocate the role according to the scenario. Then coming to the embedded participant is a participant who is from teacher's point of view. Like he will be there and he will help the scenario in a way, like suppose in a event of cardiac arrest inside an operation theater, one of the, like suppose a nurse will be an embedded participant. Embedded participant means a nurse will be like in contact with the facilitators, a teacher. And if the students are not performing the way they are expected, then embedded participant will guide them indirectly. It should not be direct one, it should be indirect one. Then coming to the last portion of the template, that is stages of scenario. This second image has shown the stages. Here that we can set the stages as need of the scenario. Suppose it's a cardiac arrest, then the first stage will be a normal, all vitals normal. Then in second stage, patient will undergo a cardiac arrest. Then you are going to assess all the participants, how they are performing CPR, what kind of role allocation is there, what kind of team ergonomics is there, whether they have used CPR board or not. You will assess everything, and if you feel like they have given all adequate medications and they have given all good quality of CPR and they have followed all the protocols of ACLS, BLS or whatever protocol you are following, then you can take the scenario either to third stage where the things will become normal, like return of spontaneous circulation, or it may get worse. Suppose a ventricular tachycardia may get converted into ventricular fibrillation, then you will assess whether they are using a defibrillator first or whether they are giving epinephrine first. So it all depends how many stages you want, and this level of stages and number of stages depends on what kind of learner you want to teach. Then coming to the components of the scenario, usually a scenario runs in 3 different parts: pre-briefing, scenario, actual scenario, and debriefing. In pre-briefing, what we do as a facilitator, when 4 learners, 4, 5, 6, whatever number we have decided, these learners will come, I will greet them, I will introduce myself, then I will ask for the introduction from the learners, then I will introduce the environment. Suppose if I am dealing with a scenario inside the OT complex, then I will introduce them to the operation theater environment. Then I will go for the introduction of the mannequin. Suppose this is the HPS, then I will tell all the features of mannequin and all the equipments. Then I will ask them whether they are having any query regarding the environment, regarding the simulation, regarding any kind of role confusion, anything, like whatever queries they have, they should be solved during pre-briefing. Then coming to the special instruction. What I mean by special instruction is, many a times we usually expect the students not to jump for intubation. Being an anesthetist, we might see that the first primary response when the patient collapses is that our student jumping for the intubation. Then if there are the residents like JR1, 2, 3, all are there, then we expect that JR3 should go for the intubation. Not just that he is good at that, but it is from a care for like mannequin. That mannequin should not get tampered because of harsh procedures. So this kind of special instruction we can always give to the participants. Then role allocation, either we can allocate them roles or we can ask them to allocate the roles among themselves. Then second part is scenario, which I will show via a video. And then comes the last portion, which is very, very, very important. That is debriefing. Debriefing is almost a soul of scenario, simulation scenarios. Why it is soul? Because in debriefing, the actual learning happens. And the debriefing also has like multiple parts like greeting, ice breaking, then looking for the reactions, what kind of reactions learners have, what kind of reactions observers have. Then we can also ask about the medical facts, where we will be discussing all the basic medical facts. Then we can also ask them as a positive encouragement about improvements. In whole simulation scenarios, everything should be in a positive manner. Even if you are trying to point out any lacunas from participant point of views, it should be in a very positive manner. Like suppose you should have done that. We can always say that you should have done that this way. But in simulation, what we prefer is how better you could have done. Like this is like in a way where we are taking the things towards positive reinforcement instead of negative reinforcement. Then we should also ask them during debriefing, like what improvements they could have done during the scenario. And if they are not able to recollect, then we can add from our points, like you perform this way, and I feel that you could have done this scenario in this way, in a better way. Then towards the end, we should ask them a take-home message and also a system change. In take-home message, we should ask them what new thing you have learned out of primary objective, learning objective, or it may not be a part of your objective at all. But they should always specify what new thing they have learned. And then system change. System change is like what they will follow in their actual practice. So this is the last part of your debriefing. Then coming to the scenario, now I will request to play one scenario. Here is a scenario, if everyone can see. This scenario is about cardiac arrest. Here, Dr. Nanivan Paliwal, who is in half sleeves white shirt, he is about to start the pre-briefing. In this scenario, we can see, like from left side, the person in blue gown is Dr. Soma. Then there is Dr. Pooja. Then Dr. Shrilek. Then Dr. Sheetal is there. Then the lady in apron, that is Dr. Pragati. Then they, in blue gown, it is that Dr. Shraddha. And after that, in a blue OT dress is Dr. Vivek. So this is a scenario about a cardiac arrest, intraoperative cardiac arrest. To explain, so here, Dr. Naveen is going to start the pre-briefing. If I can play, what he's doing here is he is introducing himself. At the same time, he has asked everyone's introduction. Then he has even now he is giving the environment. He is telling everything about environment. He is telling about defibrillator. He is telling about the monitor, what kind of features are there in monitor. He is telling about what kind of HPS features we have. Then he is telling about the mannequin, all the features of mannequin, what all things you can do. During the, you can see that everyone is asking something or the other questions to the Dr. Naveen sir. So like ma'am asked that whether you can auscultate, then she is even auscultating the patient and she's trying to listen all the heart sound. Even Dr. Vivek sir is also auscultating the patient, and he is saying, you can hear him saying that yes, I can hear heart sound and respiratory sounds also. Then he is telling that you can take IV access, you can take central line access into this patient. Then after brief introduction, as the scenario progresses, you can see like everyone has gone out of the room. Now, like you can see here, now 4 people are inside the room. Who are these 4 people? These are the people who are going to run the scenario. So in this thing, we will be taking out all the preparation we have already done. Then here we are allocating the role. Like I am allocating the role of a surgeon to Dr. Sheetal in green gown. Then I am allocating the role of a OT technician, OT assistant to Dr. Shraddha, and I am assigning a role of a junior resident to Dr. Vivek. After role allocation, we will start scenario run. Now the scenario has started, and Dr. Soma, who is in blue gown, just entered the room, and I am giving a handing over about the scenario. Scenario means like this is a 28-year-old male, a case of road traffic accident, who is having a blunt trauma on the abdomen, and now we are trying to take this patient for explore laparotomy. I have just induced the case, and now if Dr. Soma is not having any question, then I will be leaving and handing over to the Dr. Soma. Now I have given the handing over. You can see that Dr. Soma is also asking all the questions regarding the scenario. Once he is satisfied, I will leave the scenario and the actual scenario will start. Now you can see things are fine. Dr. Vivek is giving all the handing over. Surgeons have also started their surgery. But suddenly Dr. Soma notices something on the monitor. He sees that there is a change of rhythm on the monitor and ventricular tachycardia has started. Then he immediately tells Dr. Sheetal in the green gown to call for help. Dr. Sheetal will go outside and call for help, and she will call me, and I will also be party to the scenario again. 2 more people they have called for help, that is Dr. Pooja in white apron and Dr. Pragati. So we all 7 people now are going to play the scenario as a participants. Now Dr. Soma is allocating roles to everyone. He has asked Dr. Vivek to start CPR. He has allocated the role of a CPR coach to Dr. Pooja. Then he has allocated a role of a defibrillator person to me. He has asked to keep everything ready to Dr. Shraddha in blue gown. She is giving all the drugs, important needed drugs. Then the person in white lady towards foot end, she is Dr. Pragati. Now Dr. Soma has asked her to keep the record of all the drugs and events. And simultaneously, he is also giving orders to each and every person. You can see Dr. Pooja in white apron. She is assessing the quality of CPR. She is also assessing the quality of defibrillation. She is simultaneously checking the pulse. You can see her checking the pulse. So she is playing the important role of CPR coach. She is also telling that, to Dr. Vivek that your chest compressions are not adequate. And when I will be changing hand and when I will be giving CPR, she will appreciate my chest compression also. So this is how the actual scenario goes. Now you can see the scenario is progressing. The things are going to improve bit by bit. I am being assessed for my quality of CPR. I am being assessed if I am using CPR stool or not. Then we will be assessing pulse, and when there will be when everything falls in place, then we will go for end of the scenario. Why end of the scenario? Because we have followed all the protocols and we have followed all the steps as expected, the facilitator has brought the patient back. Means the return of spontaneous circulation is there. Now Soma is debriefing everyone. He is telling what went well and what all we need to do as a follow-up. He will be asking few investigations and he will also tell surgeon, that is Dr. Sheetal, to go and talk to the relatives. So you can see that Dr. Sheetal will be leaving and talking to the relatives and telling about the events happened inside the OT. This here you can see that Dr. Shraddha has brought back the investigation reports also, like ABG, and I am telling loudly all the reports about ABG so that everyone understands the reports. This way, scenario ends, and Dr. Naveen, the person in the half sleeve shirt, is back into the room, and you can see him clapping. That way, he is now ending the scenario. So this is how we end the scenario. Then we take everyone, we congratulate everyone, and then we ask everyone to come to the debriefing room. So the debriefing room is like a different room where you will be sitting opposite to each other, like facilitators on one side and learners on one side. They will sit face to face to each other, and then what they will do, they will greet each other. Then there will be some kind of ice breaking. Why ice breaking? Because when many of the times when you go into very emotionally charged scenario, you may have a very high on emotion. You might be very high on emotion. Like you might have a adrenaline rush also. You might be feeling low. You might have any previous memories of either scenario or your real life experiences. So it is a duty of your facilitator to go for an ice breaking session. Ice breaking session means to make the things lighter. You need to relax your participants. Then gradually you should ask them their reactions, like how are you feeling, how was your experience. Let them talk in their own language. Then slowly you should progress towards the medical facts discussion. Then you should gradually progress towards the improvement section, where you can discuss what went well, what went wrong from learner's point of view, and if they are not able to, if they are missing anything, then you can add from your side also. Then you can always ask them the take home message and system change. Here one of the, for a reference, I am sharing one of the debriefing slide which we had. Here we use the plus delta technique for debriefing. All these things we are going to discuss for panel discussion also. But here I will tell you in a brief that plus means all good things, delta means all improvements, and below that you can see take home message, and below that you can see system change. So during pluses, we will ask them, like learners, what they did wonderful, what they did good. Then we will also add from our side, like what was our observation. Like they had a very good closed loop communication, they had a very good handing over, like they asked about the blood and blood products, they asked about urine output, the team dynamics was good, they followed hand hygiene, they followed all psychological safety thing. Then about the delta things, we can point out all the improvements, like the certain communication was missing. Many a times what happens that the some mishap happens, we become totally focused towards the patient and we fail to communicate either with the relatives, either with the surgeon. We fail to communicate them that this thing has happened and that thing has happened. Then sometimes we might get delayed for call for help. Suppose any worse scenario happens, in that scenario we might be totally engaged with the scenario and we totally forget to call for help, or we sometimes have a hesitation also how to call for help. Then there might be confusion regarding role allocation, there might be confusion about team dynamics and also team ergonomics, like who should stand where during the scenario. Then there are some take home messages, like what good thing you will practice after this scenario in your real world. And also we should ask them one system change which will have a very long implications. Like we can always ask them, like people might be having confusion about doses during cardiac arrest. Suppose people might be having a confusion like what drug to be given for an life-threatening arrhythmias. In that scenario, we can ask the learners, suppose anesthesia residents, to make a cognitive aid. A cognitive aid can be a simple chart with all the arrhythmias, with pictorial arrhythmias, and followed by the drug or medication you can use to treat, and it should be hanged or it should be kept next to your crash cart. So this kind of cognitive help can bring a system change, and in long term, people can be benefited. Then coming towards the end of the today's lecture, we might think that we have progressed a lot. We have like almost mastered simulation. Now we have access to all kind of theories, all kind of facilities, all kind of mannequins, technology, AR, VR, and we might feel at the top of the world. But this simulation is so vast that it is just a reminder that it is just a tip of iceberg. A lot many things still need to uncover, still need to learn, and still need to progress. Thank you.
Yes. Thank you, Dr. Srilek. It was a very nice deliberation. I don't know whether we should go for panel discussion or not. You have told everything. So can you
Thank you,
show
sir.
the PowerPoint? So can you go for panel discussion?
Yes, sir. Yes, sir. Yes,
sir.
sir.
Yes, sir.
So we have a panel discussion regarding this simulation or evolution in healthcare education. So we have panelist Dr. Naveen Paliwal. He is the associate professor in SNMC, and he is the accredited national simulation facilitator. He has lot of cognitive work in the field of simulation and BCLS and ACLS. He is a NELS instructor also. Next is Dr. Next, please. Srilek, next slide. Dr. Pooja Bayani, she is the associate professor in AIIMS Bhubaneswar. She is a colleague with Dr. Naveen Paliwal in SNMC Jodhpur. Now she is in AIIMS Bhubaneswar. She is a national simulation facilitator and awarded with lot of prestigious awards. Next, please. Next is Dr. Anjali Modak. She is professor and head Department of Anesthesiology, and she is a Mayo trained certified simulation instructor. Next, please. Dr. Suma Ganesh Raja. He has fellowship in simulation from Hull, United Kingdom. He has some course in debriefing also, special course in debriefing also. He is a great man in simulation, and he is from SRMC Medical College, Chennai. So,
sir, I would like to
yes,
also.
It's okay. Myself, Dr. Vivek Chakole. Can you go to the so let's start the panel discussion. I would like to ask, Srilek has already been explained about the simulation. I would like to ask Pooja madam, if I am just passed out MD anesthesia student, and I don't, or any consultant who don't know anything about the simulation, and to be in the simulation. So what qualification or capabilities do one need to learn simulation and to be a facilitator in simulation?
So this is actually a very good question, because there are so many faculties as well as residents who come up after post-graduation and they ask, can we be a simulation facilitator? Can we be a simulation teacher? So rather than the simulation teacher, I would say we are all simulation facilitators, right? So one important thing for becoming a simulation facilitator, you should have a basic knowledge in your subject, right? Because you can tailor your scenario as per your learners group. So you should just have a basic knowledge for regarding your subject. Simulation facilitator may be from the background of anesthesia. Most of the work are being done by the nursing faculties in simulation, and various allied facilitators may be there. The first important thing is there should be certain background in the particular field. And second most important thing, because as we see, the learning and teaching method are continuously evolving. So anyone can be a facilitator, but he should undergo at least basic training in how to run a simulation. As we saw in the video as well as was run by Srilekh, there are certain technical aspects of running a scenario and to come up with learning from participants themselves, as it's an experiential learning method, right? So we should know how to do pre-brief, how to run a scenario, how to script a scenario as per the learners group, and how to do debrief. And it's altogether a different topic, right? It's altogether a different way of teaching. So as we know that the faculty teaching as well as the faculty development is a continuous process, we should have a basic training in how to train students or learners in simulation. So there are certain kind of courses being provided in India as well as abroad. Recently, we also conducted the same faculty development, faculty training program at your center, sir. So it's one of this kind, and there are certain other bodies who are also conducting these kind of simulation facilitator, simulation training programs. Second,
Madam,
yes, sir.
Any body is there or association who can certify us as a facilitator?
So in India, in India, right now, one is Pedistars. Okay, so the Pedistar body is conducting courses and it's a 3-level program, and VAST is also conducting its simulation program, and we also under RSSCP are planning under the Research Society of Anesthesiology Clinical Pharmacology. We are also planning a 3-tier program to train faculties how to run simulation sessions. And you can also tell how your experience was during this 3-level training program. From the level 1, we go with the basic training. In the level 2, we go with the virtual hand holding, in which you conduct your scenario and we will reflect on the virtual platform. And
yes,
in the level 3,
madam. It was great. In fact, SIM 3-phase program was great. It was really beneficial for facilitators.
And one important thing I want to just say, that to become a simulation facilitator, you should have enthusiasm to become a simulation facilitator, because lots and lots of planning is required for it, and to run a simulation session is definitely an art. So you should have at least basic training in simulation, how to conduct simulation.
Yes, thank you very much, madam. So now I would like to ask Dr. Naveen sir. Sir, can you please give insight about the principles or core of simulation?
Hello, good evening, everyone.
Good evening, sir.
That was brilliant presentation from Srilekh. He covered everything what needs sensitization for simulation.
Thank you, sir.
The question which was put forward to me is course of simulation. Course of simulation is the principles actually. I'll be taking only the superficial, the basics of these principles of simulation as for today's presentation or today's webinar. We will not be going in details. Starting with the first course, and the most important is celebrate failure. When I say celebrate failure in simulation, it means whenever we make mistakes, we need to accept them, acknowledge them, because to err is human. When we make mistakes, we learn from them for lifetime, right? So what simulation says, make mistakes, acknowledge them, reflect on them, and then respond. The core 2, as per simulation facilitators or simulation principle, is don't fix on shiny things. This principle emphasizes the importance of staying focused on essential aspects of the case. Rather than getting distracted by non-critical details, I will say, see, if you are planning for any simulation session, we don't need to have a high tech or high cost simulators. We can do simulation merely with low tech mannequins or half body mannequins, or even without mannequins. Only what we need to add is we need to add fidelity, reality. That can be added by adding psychological fidelity. I will give an example. See, by simply adding a difficult parenting simulation session can give a reality or a high level of immersion to the participants. Coming for the third principle of simulation, that is stay focused on I. That is trying to know unknown. Whenever we are immersed in simulation, we just focus around why this happened. If it's good, why it happens, we need to know the reason behind it. If it's bad, why it happens, we know the framework of the participant, why they did that bad decision. So by discovering this why, we promote teaching, we promote learning. Fourth principle of the simulation-based education is psychological safety. I'll define one psychological safety because most of the participants are novice to simulation. When we say psychological safety, it means that the space is conducive, that simulation space or the simulation-based education area is conducive to take interpersonal risk without fear of being consequences. That is, one should not be fear of being judged. If they are being judged, there will be only good judgment. There will be no bad judgment. By creating the psychological safety in simulation training, for the participants, they feel safe. They are more likely to actively engage in the learning process. They will put forward questions. They will share their perspective openly. This enables effective teamwork, communication, and collaboration with participants. They feel more comfortable in expressing their thoughts, their views, their queries. So by embedding and cultivating this psychological safety, simulation facilitators, they can foster a culture of continuous learning and improvement. But at the same time, we need to take account of accountability also, because high psychological safety without accountability will lead to only anxiety zone. So there should be accountability as well as high psychological safety. Then only there will be a good learning for the participants. So when I say accountability, it means that the participants taking responsibility for their actions and decisions during the scenario. The participants are encouraged to reflect the performance, identify areas of improvement, and take an ownership of their learning journey. By promoting this accountability, what happens? Simulator facilitators, they help participants to understand the significance of their actions in the simulated clinical context and how their decisions impact their patient outcomes. So by combining this both high psychological safety and accountability, this is the powerful approach to learning. When I say that the environment is highly psychological safety safe, in that case, we open participants to reflect on their mistakes. They will come up with their shortcomings. They will come up with their any adverse action or adverse reporting will be done by the participant, and we can reflect on them, and that will help in learning. The next core principle of simulation-based teaching is transaction. When I say transaction, it's from skills to the behavior. What is the biggest shortcoming of traditional teaching is it just shows, we just gain knowledge out of those in traditional teaching. There will be more of a didactic work. But in simulation-based teaching, what we do, we motivate them, we promoted them to use this knowledge in real-world care, in real-world patient care. This core principle, that is transaction, underscore the transformative nature of the simulation-based education, moving beyond the acquisition of, not only acquisition of technical skill, but promoting to lasting behavior change in the learners, as it was quite visible in our factory workshop, which was conducted in Varda at ST Trier program. There we saw there were subsequent behavior change among the participants. Now they started conducting simulation sessions more proactively. They are giving more time for preparation, planning. They are going for dry runs. They are taking care of pre-briefing. Then they have improved a lot on debriefing methodology.
I would also like to add one more thing, sir, that we have also started like observing the hand hygiene. The hand hygiene has in general improvised after that workshop.
Yes, I came to know this, that now yes, all medical personnel, healthcare personnel which are working in anesthesia department, they are practicing hand hygiene. That is now their habit. That is behavior change.
Yes, sir.
And
The next core principle, yes.
We have also taken care of psychological safety and the flattening of hierarchy.
Oh, great, sir. That's a great news. And one more thing which I came to know from the interaction with the participants or our FACSIM program was that they started giving handover using SBAR format. That is one more system change, or we may say behavior change among the participants post FACSIM workshop.
Yes.
The next core principle for simulation-based education is the power of reframing. That is from threat to opportunities. What is our traditional thinking? What is traditional thinking revolves around individuals, revolves around errors. They focus about the errors or individuals, like bad apple theory, finding the weakest link and throwing them out. But what happens? In that case, the latent system failure remains within the system. So the basic problem is still in the system. So we have to change this old thinking to the new thinking, where organization, system, resources, and development are in the focus, right? So so by thinking that there may be the several contributing factors behind the cases, behind this bad outcome, and taking this human error is a point for improvement, not for as a point for blame same game. So we need to take these threats as opportunities to use complete use of simulation-based education. And core 8, this is the most important core of simulation: know your learners. When you are going for any simulation-based education, you need to know your learner, because know your learner is a critical principle in simulation education that emphasizes the significance of understanding the unique characteristic needs and goals of each participant. This core principle recognizes that learners came from diverse backgrounds and have different levels of experiences, knowledges, and learning styles. Some may be slow learners, some may be quick learners, but we have to take care of each and every learner of our simulation-based education program. In simulation-based education, educators can create a positive and enriching learning experience. This approach fosters love for learning, empowering learners to reach their full potential and ultimately contribute to the improvement of patient outcome. And last but not the least is love your learner. See, when you love your learner, you can practice psychological safety. You will be empathic to them. You'll be transparent to them. You'll be open for them. You'll be honest to them. You'll be curious to them. And that all promotes to learning.
Right, sir.
Sir. Thank you, sir. Because learners are very important in our setup. Actually, we have learners from nursing students to the principal or head of the department or HOI also. So we have to think about their level and everything. Then we can do the simulation only. Right. So we can move to the next question like that. I want to ask Dr. Anjali, how we can apply the simulation in healthcare, particularly in anesthesia department?
Good evening, Dr. Vivek, and all my participants. Team SAMS, kindly accept my heartfelt gratitude for selecting this topic, so important topic, and for this lovely opportunity which I got today. And even I want to congratulate Dr. Srilek for covering this topic so nicely in such a less duration of time. So,
Dr. Anjali, can you start your video? We want to see you.
Yeah, sure. So, just like aviation industry and other high-risk industries like the aerospace industry have been using simulators as a teaching tool for many years. Other high-risk professions are also using this technology, just like the military, the commercial airlines, the nuclear power, and so on and so others. Our profession is also a very high-risk profession. We have to manage emergency situations, sometimes alone, sometimes with a team, sometimes it is an anticipated emergency, many times unanticipated difficulty. We have to take difficult decisions. We have to take do skillful procedures. We have to communicate effectively, not only with our team members, our nursing staff, but also with the patients and the relatives. Many emergency situations we have read only in books and never seen or encountered, but we have to do if situation arises. So in India's medical error deaths, it accounts to nearly 50 lakhs per year. As many as 98,000 deaths per year occur in the US, and these are purely due to medical errors, which can be avoided through proper training. So healthcare simulation is rapidly growing, right from teaching history taking in standardized patients, clinical skills, procedural skills, communication skills, as well as performing life-saving skills. Everything can be learned and mastered in simulation. Through deliberate practice, learners can make mistakes and learn without harming the patient in a safe simulated environment. They can take their time, they can take n number of attempts to learn and practice. It enhances the clinical competency. It improves patient safety and reduces the clinical errors. So simulation facilitates learning through immersion, reflection, feedback, and practice. So training through simulation is an adjunct and not a replacement for learning with real patients. It is an important to integrate simulation training with clinical practices during curriculum development. And it is also used for assessment of the learners. So like many situations, many scenarios, we think are must to know to our students, to our learners, to our postgraduate students, or we have to make some protocols, make them follow some protocols, make them follow some guidelines. And we have seen repeatedly that the students are not following during our routine OTs or during emergencies. We can make such scenarios, and we can take our students to the scenarios. We can take our faculties also there. We can repeatedly take practice from them, and we can bring a system change in our department and in our hospital as a whole.
Exactly, Anjali madam. That is the thing she has told. It is not the replacement for our routine education system. It is the supplementary or complementary for the education system. So I can ask Dr. Srilekh that what are the barriers and challenging in the implementing the implementing this in
yes, sir.
CBME.
Yes,
CBME.
sir. The biggest, like if we are thinking from Indian perspective, like the barrier and challenges what we have seen in implementation of simulation-based education is the policy. But now as policy has come up with like almost in all type of branches of medicine, like modern medicine, via NMC, in dentistry, in nursing, in all Indian medicine like Ayurveda, Unani and everything, they have almost everyone has made the simulation based education as a compulsory thing. So it's a very good positive thing. But coming to the barriers and challenges we are definitely going to feel is first we need to unlearn like our typical teaching, what we have gone through till now, from schools, from everything till the time we reach to the medical school. I think we need to first unlearn the way we learn things. In simulation, everything has to be has to be done under a facilitative environment. Everything need to have a very psychologically safe environment. The learner needs to be assured that you won't be judged, you won't be labeled. Whatever we are learning here, it will be judgment free. It won't be discussed outside. So first thing, I think what we need to really do is unlearn to learn the simulation way of education. Then second thing, like Naveen sir said, though cost is a big a big factor in establishing a simulation lab. But like what Naveen sir said, though cost is a big thing, a big obstacle for simulation based education, because technology has gone to a very high level. We have a very good simulators, we have a very good high fidelity mannequins. They cost a lot, but if we want to overcome this challenge of cost, like what Naveen sir said, we can always simulate things with the bare minimum equipments also. Like we can have a very basic kind of mannequin, but we can bring so much realism via props and mollages and like all kind of, like in layman's language, all kind of makeup we can use over the mannequin, and we can bring the realism. We can I will, at the end of scenario, I will definitely like share one picture what last time what Naveen sir and Pooja ma'am had developed a low mannequin which mimics high-tech mannequin. So the cost is a big factor, a big challenge for simulation-based education, but either we can overcome via recently I have read in the newspaper that Maharashtra, in Maharashtra, almost like 8 government medical colleges, government has sanctioned some 60-70 crores so that all these 8 important medical college can have their own simulation facility. But one more thing, it takes to the next challenge, like putting money is not everything. We need to also have a trained faculties and resources. Like in the same news, when I went ahead, it said that whatever money government is sanctioning, it is just for the lab. Right now, government is not having any plan to recruit resourceful personnel. So what I feel right now also that a lot of challenges are also from resourceful faculties point of view. So we need to take this challenge head on, and we need to train as much as faculties all over the India so that they can be resourceful, at least for their PGs, postgraduates and undergraduates. Then coming to the one more barrier and challenges we see during simulation based education is fidelity. Fidelity means, I mean to say, like there are 3 kind of fidelities, like functional fidelity, psychological fidelity, and physical fidelity. Physical fidelity means, like if you are creating a scenario on a mannequin, then that mannequin or that environment, suppose you are simulating, like I said, a cardiac arrest inside an operation theater, that video I played. Suppose if that though that video was having the best simulation facility, suppose that video is not looking like an operation theater, suppose that mannequin is not looking like a patient, suppose that the participants who are supposed to look like a doctor, they are not dressed like a doctor, suppose that mannequin is talking, the mannequin we are saying is a male patient, but voiceover is from a female patient. So these are kind of like physical fidelity errors. These barriers and challenges also we need to handle while delivering simulation based education. Then coming to the psychological fidelity, here in psychological means how participant is perceiving the simulation. Like you are bringing 4 postgraduates inside the simulation lab, but are they able to connect? Are they emotionally or mentally are they connected to the simulation? That challenge we need to handle very carefully, because many of the times people don't relate to the simulation based education. So how can we overcome this barrier? By bringing as much as possible realism to the simulation lab, and also to the scenario, also to the medical facts. Suppose we are running a scenario of a cardiac arrest of a young male, then that young male should look like a young male. The voiceover should be a male person if your patient is also in scenario is male. Then if you are showing it as OT setup, then it should look like OT setup. Anesthesia machine should be there, some important drugs, airway card, crash card should be there, monitor should be there. This way also you can bring the psychologically and physical fidelity. Then coming to the functional fidelity, like whatever mannequin you are using, it should do the job. Suppose you want to show a scenario of a bronchospasm, And if that fidelity is having a feature of bronchospasm, you should use it. If the person can auscultate and like identify the bronchospasm, the moment you give a bronchodilator and the spasm is relieved, the student will appreciate that thing also. The sudden change of bronchospasm to a normal breathing sound, student will appreciate, he will relate with the mannequin and he will relate with the scenario. That way we can overcome this functional, psychological and physical fidelity barriers during implementation of simulation based education. One more thing, like many a times what I earlier said, that we need to unlearn because we have gone through pedagogy, but now in simulation based education we are dealing with andragogy. Andragogy means adult learning. There are so many things we need to first learn about adult learning. Adults are very difficult, not difficult, it's a kind of little bit challenging compared to children to teach adults. So we need to also master the technique of adult learning while delivering a simulation based education. So andragogy is also a kind of challenge while delivering simulation based education. Then like what kind of Naveen sir already highlighted, like how can we overcome all these challenges and barriers? By bringing a kind of psychological safety, that we should always assure our students that they are psychologically safe, they will not be judged, and they can make them comfortable in the scenario, and they can ask whatever they want to ask about the scenario. Then we can have a fictional contract. Fictional contract, I mean to say that we will have a kind of contract that whatever we will be doing here, we won't be discussing it outside. Suppose we are teaching our PGs inside a simulation lab, and like they are doing some mistakes and we are discussing it outside the simulation lab inside OT, it won't keep that fictional contract intact, and that psychological safety will be hampered. Then we need to also take care of the suspension disbelief, that learners should be able to suspend their disbeliefs. Whatever disbeliefs they are having, they should suspend, and then only they can connect with the simulation based education. So what I feel as much as realism we bring to the simulation, as much as comfort and psychological safety we bring to the learner, the simulation based education can really make a big impact in medical education.
Yes.
And it can be overcome by many solutions.
Exactly. Dr. Srilekh has explained my next question also, and he has explained the strategies also. And I am very lucky that I have the resourceful faculty like Dr. Srilekh, and we have adjunct faculty like Pooja Madam, Naveen Madam, and Soma sir. So can we take next question? I would like to ask Pooja ma'am, how non-technical
sorry to interrupt you here. Actually, I'd like to add few things about the previous question.
Sir, please.
Srilekh very well explored the barriers as well as possible solutions for those barriers. But after going through this practicing workshop at our institution at Wardha, what I came to know from the faculty's feedback was that the biggest barriers for simulation-based education are what I felt after going through this feedback is the faculty time constraint. Most of the faculties, they are preoccupied with some or other tasks in their respective clinical areas. That was the one biggest barrier which I felt. The second was the lack of trained faculty pools. We have faculties which are trained in some or other ways of simulation programs, but there was no uniform program, or uniformity was lacking among the faculties. The third thing which I got to know from this feedback was the lack of supportive staff. See, that was actually to our institution, it was not that imperative because we have a good supportive team with us working in simulation center. And the fourth, which I felt, is the cost of equipment. So as we have suggested for faculty time constraint, we focused during our simulation the sessions also that we can conduct even in situ simulations. That is where the clinical areas where we are working, we can conduct simulation sessions then and there itself to take care of the time constraints. There you have your residents, you have your co-faculties, and you can do simulation session while on your clinical area. So this is how we can overcome these time constraints. The second was lack of trained faculty, that is faculty with certified courses. So for this, we have started this program, faculty development program under the RSCP. And this was our first, or we will say pilot workshop, which we conducted in Varda from June to August. And we are soon we'll be going to certify the participants of this workshop once they complete their level 3. And this will be done in RSCP on 2025 at Bathinda, the next conference. Right? And our next batch, we are planning in the same conference. The third thing which we came across was cost of equipment. That Srilek highlighted very well. We don't need high-tech mannequins. We can create appropriate realism or fidelity with low-tech mannequin using appropriate probes and moleges by taking in situ simulations and by using those online freely available apps. And lack of supportive staff, yes, we need a pool of supportive staff which can help us conduct all these simulation sessions. For this also, we need to have stakeholders to take stakeholders in the loop and explaining them the importance of simulation and simulation-based education. Now, at this moment of time, if we don't give this opportunity to our participants to learn or to be in simulation-based education, then it's unethical.
Yes. Thank you, sir. Thank you very much. I would like to ask Pooja ma'am, how non-technical skill can be developed from this simulation?
Yes, sir. Actually, if we talk about the non-technical skills, these are basically our cognitive and social and personal skills that will just complement technical skills that we have and ultimately contributing to the safe performance of during procedure, right? If we are in this 21st century and we know that most of the technical work will be done by robots or AI in the next decade. So even sometimes we don't need any human being for performing this technical part. So here comes the importance of non-technical skills like communication skills, how to work in a team, how to do leadership during a high-stake crisis situation, decision-making, right? And situation awareness. And sometimes even in the emergency situation, we are so much stressed. So how to cope up with the stress and fatigue during high-stress situation, we all can practice during this simulation. One example I would say, as Dr. Anjali also highlighted, the more than 90% of the claims in US are because of human errors. So we think like technical part is mostly done and mostly taught in the postgraduate as well as undergraduate program, but we lack in teaching the non-technical skills. So how can we teach? Just if we go about the video, here also we can see the ergonomics, how one should stand during crisis situation, just because that was a high-stake crisis situation, the CPCR video. Okay, so the leader is standing at the bed end side and he is giving commands, he is allocating the role, and there was a closed loop communication between all the members. So these are the skills, communication skills between the team members as well as with the patient, with the other interdisciplinary communication can be taught in the simulation. Second point highlighted by Dr. Naveen was the SBAR format of handover, which was also improved after this workshop. This also, we don't need even the high-tech mannequins. Even during in-situ simulation, we can teach our students the SBAR format of handover and communication. Next is like about the teamwork and collaboration. So teamwork is important because most of the time in our medicine, we are working not solely. We are working as a team, like a team of anesthetists, nurses, physician, and surgeons. So This teamwork and collaboration should be taught in the simulation and can be easily experienced and practiced during simulation. One important part of simulation is the crisis resource management training, because in the high-stake emergency situation, the most of the errors are because of fixation errors. We fixate on something and we do not perform this timely decision. Like if we talk about the airway management situation, most of the time the errors is because we fixate on certain thing and we keep on intubating sometimes, right? So here early call for help and how to go from one step of algorithm to the next step of algorithm. This all can be practiced during running scenario, as well as most of the things can be discussed and learning can occur during debriefing sessions. So this simulation is the best way to teach non-technical skills and to practice non-technical skills, I would say.
Exactly. Thank you. Thank you so much, madam. Next question I can take with Dr. Soma sir. He is waiting since long. Huh? How can an educator or facilitator ensure the learners get the most out of simulation experience?
First, I would like to thank everyone for inviting me and giving this opportunity for participating in this webinar. I think I congratulate Sri Lake for taking a mini fellowship in simulation with his talk. I think as an educator or a facilitator, it is our responsibility to make sure that the learners get the most out of a simulation experience, especially if we are a simulation educator. So I would start with basic assumption. So my mentor in simulation is Jenny Rodolph from Center for Medical Simulation, Boston. So the motto of CMS is everyone participating in activities in simulation scenarios or simulation programs is intelligent, capable, cares about doing their best, and wants to improve. And if we hold this basic assumption to our heart, right from the start of our pre-briefing or right from the first interaction with the learner till the learner leaves the sim lab, that will make sure that the learners gets the most out of simulation experience. And coming to the next thing is this basic assumption will also build a sense of psychological safety among the learners so that they will be more interested in participating in the simulation experience. They will come out of their cocoons and they will share their learning frames, and then we can work upon the learning frames to know what are the learning frames that led to their actions and that led to the results that they have done in the simulation scenario. And we can reframe their frame of mind so that they will have new actions and new results that will be as a take home or a sign off. It could be a clinical sign off, it could be a skill sign off, it could be a behavioral change, it could be anything depending upon the learning objective that we are having. So with this psychological safety built up by basic assumption, and one another important thing called as positive judgment. So there's nothing called as we always judge people at any point of time. There is nothing that I even psychology texts, they don't believe that people do not judge. Or if someone says I do not judge, it will be hard to believe. Everyone judges. The basic core principle of debriefing is judging with good intent, or there's nothing called as debriefing without judgment. So we need to inculcate some positive judgment. For that, we need to be open-minded. We need to be more curious to know the frame of mind of the learner. So that will take us a long way to make sure that the learner is going to get most out of the simulation experience. And then adherence to best practices. That there are lots of best practices that have been laid by the ASPE, that's the Association for Simulator Practitioners in UK, and by the SSIH, that's the Simulation Society for Healthcare, that's from US. And there are lots of CSAM, that's from Europe. So there are lots of simulation societies and associations they have come up with, and the INACFL from US. So they have come up with lots of best practices that we need to follow during our pre-briefing, during running a scenario, as well as during a proper debriefing. And that includes the signing off. This will make sure that the learner takes the best out of the learning experience. So with these basic core principles of psychological safety, a curiosity, a basic assumption, and fictional contract as explained by Sri Lake, and adherence to basic principles of pre-briefing, running a scenario, and giving a proper debriefing will make sure the learner has been inculcated with the best knowledge or skills or whatever the learning that the learner is going to take forward. So we can also you can also incorporate a single loop or a double loop learning using simulation. So that will go in a long run with clinical skill acquisition or a team or system development or a behavioral understanding, efficiency, and so on and so forth, depending upon the zone of the learner, that zone of the simulation that we are going to do. So we can isolate the clinical content by reducing the clinical signal and noise and make the clinical learning as in zone 1 or zone 0 learning. Or we can have a given hybrid learning as with high fidelity simulators, or we can develop a team or a system with zone 3 or a zone 4 simulation, depending upon the learner that we are going to cater to. So there is n number of things that can be taught, that can be learned by an adult learner during the simulation program. And more importantly, when we stick to the basic principles of simulation, I feel the facilitator will definitely ensure that the learner will get most of the simulation experience. We don't need a very high fidelity simulator with crores and crores of money that's invested to create a simulation scenario. With basic low fidelity simulators, low fidelity mannequins, or even sometimes without even mannequins, we can create a scenario, we can design a scenario. And when we stick on to basic principles, just with our clinical practice, in simulation practice as well, when we stick on to the basic principles, the learners will get excellent learning, out of the simulation experience that they are undergoing. Whereas there are a number of literature that supports that a simulation, the learning curve of simulation is like a steep that goes above when compared to the clinical learning that is being done for, or the didactic teaching that's being done regularly. I think I will cut short here for the want of time. Thank you, sir.
Yes, sir. Thank you. Thank you, sir. Thank you. Just continuation of this question, I would like to ask Naveen, sir. Sir, can you give any example how simulation has improved outcome in real world?
Sure, sir. One live example is our FACSI workshop. I'll start with it. We have evaluated this workshop pre and post both, and we have got a very significant responses from participants, like regarding satisfaction of the participant by the content of our workshop, then with facilitators and the environment we were able to create. And we are very happy that we are able to see several system change after this FACSI workshop, as stated by our participants, like hand hygiene has become a behavior in Warda Medical College post this workshop, one thing. Then ASPA format of handover is again a behavior change. That is in a real clinical world. Then another one is psychological safety. Now all, right from the hierarchy of the senior professor to the resident, they are taking care of psychological safety. So they are now working as a closed container, helping each other learn. Then there is a number of literature available around the globe about this change in about the impact of this simulation-based education in real world. There is a narrative review published in BJA very recently in 2019 about use of simulation to improve management of palliative anaphylaxis. They concluded that in situ simulation use of cognitive abilities to improve teamwork and task performance. That is, they found significant improvement in non-technical skills, that is soft human skills, which is the backbone of our specialty, especially in anesthesia. Then there's another another article published in Resuscitation, a prestigious journal, about educational course including medical simulation for early gold therapy. There they have prepared a 5-hour course including didactic lectures, skill workshops, and a simulated case scenario for septic shock, where administered to the participants, and they evaluated them pre and post regarding the knowledge gain, regarding the skill gain, and regarding the address to the septic bundles. And they found that medical simulation is an effective method of educating early goal-directed fluid therapy and in the severe sepsis resuscitation bundles. there is another meta-analysis. This is again published in BJ, where simulation-based training in anesthesia was compared to non-simulation-based training, and they found that other than time constraint, they favored technology and non-simulation-based training, and from the point of views as participant satisfaction, knowledge and skill gains, change in behaviors, and patient outcome. I can even enumerate a number of studies furthermore about these changes in real world post-simulation based education or post-simulation based exercises. There is another study at our institution conducted by us, me and Pooja, where we have assessed the use of ventilator bundles to address to the ventilator bundles in ICU staff and resident doctors. And if we found that a baseline, it was just 40% among our ICU staffs, which has increased to more than 90% post-simulation based educations. And this has drastically reduces our VAP incidences in our institute. There are several case studies presenting about decrease in catheter-related bloodstream infections, VAP mortalities in ICU post-simulation based educations.
Yes, it is. I am very happy that we have also get IEC approval for that FACSIM workshop, the effective outcome for the FACSIM workshop. It is under the Dr. Srilek, Naveen sir, Pooja ma'am, Soma sir. So we can see the outcome in next two year like that. It is a long study, but we can see the outcome till the return of investment income in terms of the education also. So, Dr. Soma, can you share any example of successful simulation program?
Yes, I think Dr. Naveen has rightly pointed out the FACSIM program. So when we employ the Kirkpatrick evaluation, the reactions after the workshop was excellent. I think the people were willing to change. The change was evident in their faces as seen in as seen by the reactions. And then there were a lot of learning points when we discussed, and they also talked about the behavioral change and the end result. Just as, for example, Srilek mentioned about the hand hygiene that has brought in a great change in their institute. I was a part of the STARS program, which is the simulation training for acute and routine scenarios. That's a training program for international graduates, international medical graduates who are entering UK when I was doing fellowship in simulation there. So it was like people from all across the country, from Eastern Europe, Africa, Southeast Asia, and a few from Canada. So they were part of the program. And then it was very easy after at the end of the program that they have all evolved so that they can be incorporated and into the NHS in the UK system of healthcare. So just with one program for 3 days, it just made a makeshift idea. Their mental model has changed in such a way that they were ready to serve the NHS in UK. So that's one powerful program that I would always remember. And it is not that such international program or a national program or a workshop, but then even in a day-to-day, whenever I engage with postgraduates, I create some mini scenarios and then I try to discuss the things with them. And then that will bring in a lot of behavioral change. It will bring in results. And next time when I interact with my postgraduate students, I will feel more happy that that simulation scenario, a mini scenario, has brought in the necessary change that will make him as a better anesthesiologist in his career. So I think these are a couple of things that I would like to share with you. Thank you. Sir, you're muted, I think. Can you unmute and speak, sir?
There are a lot of success stories regarding the simulation outcome in research also. So the most important thing about the costing of the sim lab. Can you explain, Dr. Anjali, about the costing?
Yes, it's a very important consideration. Cost is a very important consideration. Setting up a simulation lab is an expensive affair. Expenses can be divided into various heads like cost of land or office space. Like Srilek has already mentioned that NMC has specified that 600 square meters area for intake of 150 MBBS students is a must, and that's 800 square meters is must for 200 to 250 intake. So space, or the cost of land is it will always be there. Then the cost of mannequins, including the task trainers and the minimum required list, is mentioned in the document. The NMC has also mentioned the number of task trainers required and what task trainers are required. So they are very specific on that. Then we require audio visual aids, equipments. We require computers and technology. Then we require the recording system, furniture, then the maintenance of the mannequins and the updation and their insurances. Then the computer-based software programs we have to buy. Then we have licenses. Then we have employees' salaries of the trained facilitators and the faculties. Then the medical supplies and consumables are always there. And then to create like environmental fidelity, like to create OT setup or ICU setup or an ER environment, we require so much of equipments and facilities. So the cost can vary depending on the variety of factors, including which city the lab is to be based, the size of the facility, the equipments being used, the make of the equipment, the fidelity of the mannequins, whether you want a basic lab or an advanced lab, and how trained your faculty and manpower are. So the startup cost can range from 5 to 15 crores, and it will increase as you add higher fidelity mannequins to the list. And maintaining and updation of the simulators and equipments is also an ongoing process. Around 10% to 20% of the initial purchase prices annually is the ongoing price annually you have to pay. And it is quite expensive to set up a skill lab, but there are many leasing and financing options also available. So our institute, we are lucky that our management has invested so much in the sim labs, and we have a high quality and a very advanced lab. But yeah, it is a very costly affair.
Last two questions are there. Just discussion. Naveen sir, how do you address faculty development and training for simulation facilitation?
Yes, sir. See, addressing faculty development and training for simulation facilitator involves a structured approach. I will take example of our TOT program, FACSIM. What we have proposed is, we have proposed a 3-tier training program for training of trainers. For that level 1, that is the basic sensitization to the simulation-based education, will be a contact program, a 2-day contact program. Here, what we are doing is, we are going for a needs assessment. Needs assessment. What I mean by needs assessment, we will be conducting a survey about the basic knowledge of the participants and their perception about simulation-based education. What are their concerns and what they want out of this simulation TOT. Then after going through this needs assessment, we'll be having a structured program, 2-day program, where we'll be teaching them how to develop a curriculum based on needs assessment, how to develop a scenario script, then how we can conduct a simulation session right from preparation to pre-briefing to scenario run and debriefing. We'll be taking the basics of all course of simulation. Then in second level, that is level 2, we'll be giving them scripted scenarios to run. So each of the participants, we want them to run 5 to 6 scripted scenarios in their institutions and to come for reflections virtually with mentors one-to-one. And there they will be learning how they are going to run these simulation scenarios under the mentorship of trained simulator facilitators. And in level 3, we are proposing a hybrid mode. That is maybe a one-day physical or a virtual hand-holding in level 3. There they're going for higher levels. That is for difficult debriefings, like difficult learners with a difficult behavior or difficult situation, how to deal with those things. Then what all evaluation methods we can use to assess the simulation-based educations, and of course our research, simulation-based research on simulation. The participant has to conduct one protocol or have to prepare one protocol for simulation oriented research, so that they have a idea about what all research is going around globe about on simulations, and they will be benefited by that research of knowledge from going through those research activities. And someone in chat box also was querying about this certified courses in India. So I think Dr. Pooja has also highlighted, and then Cyrillic is also highlighted, and me also. I'll again repeat for them that yes, there are few organizations which are conducting certified simulation courses. One among them was Padistas, but they are focusing mainly on pediatric simulations. And another is MEO, which is mostly virtual, and one more was highlighted by Pooja was this one, the US accredited certified course, and the one which we are offering is RSCP, that is the Research Society of Anesthesia and Clinical Pharmacology accredited simulation TOT course that will be certified by Research Society of Anesthesia and Clinical Pharmacology.
Vivek sir, you are muted actually.
So, Soma sir, how do we see simulation evolving in next 5 to 10 years, particularly in Indian setup?
I think that's a really a tough question to answer. But then India is going leaps and bounds in simulation healthcare. From the healthcare point of view, simulation is there's lots of research going into AR and VR. It's augmented reality and virtual reality. I think one of the noted companies is Medicine VR, that they are doing good work in incorporating virtual reality in simulation-based education. They have found that in one of their research that there is a 78% improvement in clinical skills among novice doctors as well as for nurses when they have used the virtual reality programs. So the virtual reality is very easy. It doesn't need, I think, the data shows that around it needs 40% of the money that is needed to establish a simulation center. And then the pitfalls of the simulation, that some of the high fidelity mannequins, which is difficult to reach the realism, or like showing a facial palsy or moving around, showing a jittery patient or emotions or victims of abuse. These things cannot be depicted very clearly or very easily by the even by the high mannequins, which can be overcome by virtual reality. It gives us, we have a 360-degree video recording that happens usually when we are into the virtual reality and simulation. So that gives us an overall view of how we are ergonomically positioned, how we are talking to the patient, and how we are utilizing the resources, what are the non-technical skills we are using, what are the challenges we're facing. And so it gives an overall sort of a multi-source feedback that is given by the virtual reality itself. In fact, the artificial intelligence that's incorporated along with point-by-point data. So a couple of years back, when I worked on HoloLens of Microsoft in virtual reality, I found that It's just it's very easy to learn the haptics of the HoloLens, and then it gave me lots of feedback on the challenges that I was facing, including the language barrier, including the communication skills, everything it gives us. So I feel that will be the way forward for simulation in medical education. And it also gives us a comprehensive assessment about the psychological makeup of an individual as well. So that can also be taken care of, and we can, whatever the gap or a skill gap or an attitude gap, whatever it is, that can be filled very easily with using an VR simulation. And cooperation of artificial intelligence, that is creating a huge breakthrough, especially in simulation field. And when it comes to medical education, I feel a decade or so, simulation-based, simulation-based assessment is going to be the norm for every specialty, especially when it comes to attitude, ethics, communication skills for undergraduate learners. And postgraduates like in emergency medicine or anesthesiology, probably how they diagnose the patient or how they handle a crisis will be assessed as part of as a final university exam or something like that. And before going to the need of the hour is integration of into the medical curriculum for post education. I think integrated into the graduate medical education, but it's the need of the hour. But once that's done, I think that will be the way forward. I think lots of medical college setups have, especially anesthesia departments, they have come up with their own simulation labs for their to train their postgraduate students. So I think those learners will benefit a lot. They will have an edge over other learners when their peer groups, they don't get trained in simulation. And I think with VR and AR, I think it's much more cost effective. And I think it has made a huge in the US, but in India, I think it will very soon, because we have large amount of data that is that's collected through which none of the country has. So I think probably after a decade or so, we will be leader. Good thing is we will create an Indianized version of whatever simulation that we have learned from the West. I think that will cater to our own population. I think that make a huge breakthrough in the field of medical education. Thank you, sir.
Yes, sir. I can see a bright future for Indian simulation, at least for anesthesia. Is it okay? Is it right, sir?
Yes, sir. I think I would say, because I think the anesthesia for the CME programs or the conference, the workshops, simulation has become a part of the workshop for almost all conferences, and people have started realizing the importance of simulation and being incorporated into it. And then from an anesthetist point of view, we can go inside the OT, inside the PACU or an ICU, and we can train our learners in a much better way. I would probably, it might be an exaggeration, but I would say simulation is a form of gurukul. The guru is school, and probably everyone is a guru and everyone is learning from everyone, making the learning a pleasant experience for everyone. Yeah.
Yes, learning is the continuous process, and we have to work hard to take the simulation at higher standard. Right, sir? So thank you, everyone. My panelists, Soma sir, Pooja ma'am, Naveen sir, Shrilekh, Anjali. Thank you very much. Hope everybody enjoyed the this webinar. Over to Tagatpalle sir.
Thank you, Chakole sir. As such, simulation is a very vast topic, and it is really very difficult to conclude the simulation topic in a 1.5 hours. I really appreciate the efforts taken by Dr. Chakole sir, Shrilekh sir, and a panelist. I would like to say here that this webinar on the simulation was an excellent webinar till now we have taken. We are in the webinar. I'm very much thankful to Dr. Vivek Chakole sir, who has taken very much effort for this excellent webinar. And in one say, when we have visited Wardha, the simulation lab, we were very much impressed with the simulation lab, and we put a word to Dr. Chakole sir that we'll keep one webinar on this. So he has prepared well in a very short notice of time, and I'm really thankful to him. I'm thankful to Dr. Srilek for his excellent introductory lecture, simulation with the scenario videos also. I'm very thankful to the panelists, Dr. Naveen Paliwal sir from Jodhpur, Dr. Pooja Bihani madam from Bhubaneswar, Dr. Anjali Modak ma'am from Nagpur, and Dr. Soma Ganesh Raja Nitirajan sir from the Chennai for a very excellent panel discussion on the simulation. I'm very much thankful to Dr. Balaji Asegavkar sir, Dr. Anita Nete ma'am, Manisha Katikar ma'am, Indrayani Hemant Kumar ma'am, Charuta madam, Avinash Bhosle sir, and thank you to all SAMS members who were attending the webinar. And thank you all. With this, we will conclude this webinar. Thank you very much.
Thank you, sir. Thank you very much. On behalf of
Excellent. Congratulations, Vivek sir.
Thank you, sir.
Wonderful
Thank you very much, sir.
Srilek.
On behalf of our team, I should thankful to the Asegavkar sir, Nehate madam, and Rajesh sir. Thank you very much, sir, for giving us the opportunity. It was a great pleasure for conducting this workshop webinar.
Thank you.
Excellent
Excellent
webinar. Excellent webinar.
Thank you. Thank you.
Thank you. Thank you very much.
Bye. Good night.
And hopefully we can
Okay.
take next stage of this program in your
Yes.
sir.
Yes,
Yes,
sure.
very sure. Very sure.
Yes. Right. Thank you, sir. Thank you.
Good night.
We should promote simulation. Right, sir. Thank you. Thank you very much.